Today we're gonna talk about fluid management. Total body water. Water comprises approximately 60% of lean body weight in men and 50% in women. Total body water is distributed in two major compartments. Two-thirds is intracellular fluid and one-third is extracellular fluid. The latter is further subdivided into intravascular and interstitial spaces in ratio of 1 to 4. The intravascular compartment would contain about 3.5 liters of water. For example, the plasma volume, not including the water content of the cellular elements in blood, which by definition would be intracellular fluid, and the interstitial component is 10.5 liters. Disturbances in total body water would manifest primarily as changes in the osmolality of the fluid compartments. Total body sodium. 85 to 90% of total body sodium is extracellular. Because most of the body's sodium is in the extracellular fluid, alterations in sodium content are manifest clinically as extracellular fluid volume depletion, as in hypotension, tachycardia, or extracellular fluid volume overload, peripheral and or pulmonary edema. Sodium concentration is distinct from sodium content, since one can have reduced serum but increased total body sodium as occurs in heart failure. Treatment of the euvolemic patient. Maintenance fluid therapy can be provided enterally or for patients who are unable to take food or liquid by mouth intravenously. The patient who can be allowed free access to food and drink should be allowed this rather than providing parenteral therapy. Weighing the patient daily is the best means of assessing net gain or loss of total body fluid, because gastrointestinal, renal, and insensible fluid losses are unpredictable and difficult to quantify accurately. A decision to provide intravenous maintenance fluid therapy should be an active one rather than by rote. There are indications or contraindications and adverse effects of intravenous fluids just as for any medication. Intravenous fluid therapy should therefore be reassessed at least daily, just as the inpatient medication list is reviewed at least daily. Consider the water and electrolyte needs of the patient separately when prescribing intravenous fluid therapy. Minimum water requirements for daily fluid balance can be approximated from the sum of the minimum urine output necessary to excrete the daily solute load. That's to say from 500 to 675 milliliter per day, which assumes an average solute load of 600 to 800 milliosmolar per day, and a maximum urine concentration capacity in healthy kidneys of 1200 milliosmolar per liter. The water lost in stool is approximately 200 milliliter per day, and the insensible water losses from skin and respiratory tract are each approximately 400 to 500 milliliter per day. The volume of water produced from endogenous metabolism is approximately 250 to 350 milliliter per day should be subtracted from this total. This comes to a minimum of about 1400 milliliter per day or 60 milliliter per hour of water needed for maintenance. If the patient has any drains in place, these losses must be factored in the total water requirement. It must be kept in mind also that insensible water losses depend on respiratory rate, ambient temperature, humidity, and body temperature. Water losses increase by 100 to 150 milliliter per day for each degree of body temperature over 37 degrees Celsius. Fluid losses from sweating can vary enormously, from 100 to 2000 milliliter per hour. It's not uncommon to administer 2 to 3 liters of water per day to produce a urine volume of more than 1000 to 1500 milliliter per day, since there is no advantage to minimizing urine output. The electrolytes that are usually administered during maintenance fluid therapy are sodium and potassium salts. Requirements depend on minimum obligatory and ongoing losses. The kidneys are normally capable of compensating for wide fluctuations in dietary sodium intake. Renal sodium excretion can fall to less than 5 milliequivalent per day in the absence of sodium intake. It's customary to provide 75 to 175 milliequivalent sodium per day as sodium chloride. For comparison, a 2-gram sodium diet provides 86 milliequivalent sodium per day. Generally, 20 to 60 milliequivalent potassium per day is included if renal function is normal. Carbohydrate in the form of dextrose 100 to 150 gram per day is given to minimize protein catabolism and prevent starvation ketoacidosis. The electrolyte losses from insensible losses may be disregarded since these fluids are quite hypotonic and may be regarded simply as free water. If the patient has ongoing gastrointestinal or renal losses from surgical drains or disease states such as diarrhea or salt-wasting nephropathy, these electrolyte losses should be accounted for and added to the total daily requirements. Gastrointestinal losses vary in comparison and volume depending on their sources, and predictions of daily requirements based on this information may be made. Alternatively, laboratory measurement of the electrolyte composition of these gastrointestinal losses can be performed to increase the accuracy of replacements. Using these guidelines, one can derive a typical maintenance fluid regimen for a patient. That is, dissolving 150 milliequivalent sodium, 40 milliequivalent potassium, and 100 gram dextrose in 2 liters of water to be given over a day. These values were chosen arbitrarily but are within the ranges of daily water and electrolyte requirements described. Would give a vinyl solution consisting of 75 milliequivalent per liter sodium and 20 milliequivalent per liter potassium and 50 gram per liter dextrose. Related scenarios with other ongoing gastrointestinal or renal losses can be approached in a similar way by determining the total water and total electrolyte losses separately and choosing the appropriate fluid to match both of these losses. The hypovolemic patients. Etiology. Volume depletion, as we perceive it clinically, generally results from a deficit in total body sodium content as a result of renal or extrarenal losses that exceed sodium intake. Larger amounts of water alone must be lost to manifest as volume depletion, since most of the loss, two-thirds of it, occurs from the significantly larger intracellular fluid compartment, which is not easily accessible to clinical and laboratory examination. Renal losses may be secondary to diuretics as pharmacological or osmotic, salt-losing nephritis as medullary cystic disease, chronic interstitial nephritis, polycystic disease, mineralocorticoid deficiency or the tubular dysfunction, and osmotic diuresis from resolved acute tubular necrosis, or the relief of bilateral urinary tract obstruction. Extrarenal losses include fluid loss from the gastrointestinal tract, as in vomiting, nasogastric suction, fistula drainage, and diarrhea. Also respiratory losses, skin losses, especially with burns and hemorrhage. Another major consideration should be third space accumulations as occur with peritonitis, pancreatitis, portal vein thrombosis, ileus, or intestinal obstruction, bacterial enteritis or colitis, crush injuries, and rhabdomyolysis, and during the postoperative period. Clinical presentation of hypovolemic patient. A thorough history and physical examination are generally sufficient to determine the presence and cause of volume depletion. Symptoms are usually nonspecific and secondary to accompanying electrolyte imbalances and tissue hypoperfusion. These include complaints of thirst, fatigue, weakness, muscle cramps, and postural dizziness. Sometimes syncope and coma can result with more severe volume depletion. Signs of hypovolemia include low jugular venous pressure, postural hypotension, postural tachycardia, and the absence of the axillary sweat. Diminished skin turgor and dry mucous membranes are poor markers of decreased interstitial fluid. Mild degrees of volume depletion are often not clinically detectable. Larger fluid losses often present as hypovolemic shock and heralded by hypotension, tachycardia, and signs of hypoperfusion such as cyanosis, cool extremities, oliguria, and altered mental status. Laboratory studies of the hypovolemic patients. Laboratory studies corroborate the clinical suspicion. High urine osmolarity, low urine sodium, and contraction alkalosis may be present but cannot be relied upon. These data would be affected by the acid-base characteristics of the lost fluid and by the renal disease that may be causing the volume depletion in the first place. Sodium does not reflect total body sodium content and therefore is not helpful in diagnosing sodium depletion. However, since it's intimately related to osmolarity, sodium does predict alterations in total body water. A high serum sodium suggests the presence of a water deficit, which would be replaced as well. There may be a relative elevation in the hematocrit and serum albumin from hemoconcentration. Treatment of the hypovolemic patient. It's often difficult to estimate the volume deficit present. Weight loss can help in estimating the total volume deficit. The extracellular fluid deficit can be estimated from the formula. Extracellular fluid deficit is equal to 0.2 times lean weight kilograms times hematocrit divided hematocrit USU minus 1, where the hematocrit USU corresponds to the patient's usual hematocrit when he or she is euvolemic. Unfortunately, the patient's euvolemic weight and hematocrit are not often known. Therapy is thus largely empiric and requires frequent reassessment of volume status through attention to the signs noted above while resuscitation is underway. Mild volume contraction can usually be corrected via the oral route. More severe cases of hypovolemia require IV therapy. The therapeutic goal is to first replenish intravascular volume with isotonic fluid and then restore the total body volume deficit as well as ongoing losses with fluid similar in composition to that being lost. The latter is done in a manner similar to that described in the calculation of maintenance fluids, where the water and electrolyte losses are accounted for separately. Perturbations in volume status, the euvolemic patient. Normal saline 0.9% sodium chloride is the initial fluid of choice for replenishing intravascular volume, especially in patients with hypotension or shock. Only approximately one-third to one-fourth of the administered volume of an isotonic fluid will remain in the intravascular space, and the rest will leak into the interstitium. This is explained by the fact that the extracellular fluid is divided into intravascular space and interstitial space in a ratio of 1 to 4. Again, frequent assessment should occur during resuscitation. Patients with significant hemorrhage or anemia may require blood transfusions. One safe strategy for intravascular volume repletion would be to administer a bolus of isotonic fluid, either normal saline or Ringer's solution. Hypoosmolar solution should never be used when bolusing to avoid the possibility of causing intravascular hemolysis in a volume of 1 to 2 liters, depending on the fluid deficit. After completion of the bolus, one should examine the patient for signs of improved hemodynamics, for example, improved heart rate, blood pressure, and/or urine output, and for clinical evidence of impending volume overload, with particular attention directed to the neck vein and pulmonary exams. If the patient still appears to be intravascularly volume depleted, then another iteration of the cycle of bolus followed by reassessment should be undertaken, and so on. Modifications to this strategy for poor cardiac reserve should be made through decreasing the size of the fluid bolus even to as small as 250 milliliters, rather than decreasing the bolus infusion rate for all but the most profound status of heart failure. For example, you estimate a patient who has been vomiting for 2 days and has a total volume deficit of approximately 8 liters. After bolusing a total 3 liters of normal saline, you feel the patient is intravascularly replete. The patient continues to have 250 milliliters of emesis every 8 hours. A goal of repletion of the total body deficit in 24 hours is reasonable. The patient had 1400 milliliters per day times 2 days is equal to 2800 milliliters of obligate water loss, and will lose an additional 1400 milliliters during the next 24 hours of therapy. Therefore, fluid loss in emesis totals 5200 milliliters, which is 8000 milliliters minus 2800 milliliters, plus an additional 750 milliliters over the next 24 hours to total 5950 milliliters. The sodium and potassium deficits can be estimated with a knowledge of the typical components of stomach fluid, or by the laboratory analysis of the emesis, and are 595 milliequivalent for sodium and 59.5 milliequivalent for potassium. The hypervolemic patient. Etiology. Hypervolemia, as perceived clinically, results from an increase in the total body sodium as a result of salt intake that exceeds renal sodium excretion, usually because of relative renal sodium retention. Sodium retention can be caused by a primary renal disorder such as renal failure or the nephrotic syndrome. Alternatively, it may be secondary to decreased effective circulating volume that results from heart failure, cirrhosis, or profound hypoalbuminemia. Hypervolemia can also occur with normal renal sodium excretion during volume resuscitation with fluids with significant sodium content. Diagnosis of hypervolemic patient. Clinical presentation. Volume overload is most apparent in the extracellular fluid compartment, again because this compartment is most accessible to clinical and laboratory evaluation. Signs of extracellular fluid volume excess results from expansion of the interstitial compartment, which presents as edema and effusions. Incipient edema may be detected only by the occurrence of weight gain, whereas overt edema is apparent only after 3 to 4 liters of fluid has accumulated. Expansion of the intravascular compartment of the extracellular fluid results in pulmonary rales, elevated jugular venous pressure, hepatojugular reflux, and S3 gallop, and sometimes hypertension. Symptoms may include dyspnea or complaints of peripheral or abdominal swelling. Laboratory studies. Laboratory studies are generally not needed and hypervolemia is primarily a bedside diagnosis. Serum sodium does not reflect total body sodium and therefore is not helpful in establishing the presence of a sodium surplus. The urine sodium may be low, less than 15 milliequivalent per liter, in states of decreased effective circulating volume, reflecting renal sodium retention. A chest radiograph may show pulmonary edema or pleural effusions, but clear lung fields do not exclude volume overload. Treatment of hypervolemic patients. Treatment must address not only the extracellular fluid volume excess but also the underlying pathological process. The main arms of therapy are limiting sodium intake and promoting sodium salt wasting through the use of diuretics. Treatment of the nephrotic syndrome and the volume overload associated with renal failure is discussed. Treatment of heart failure and cirrhosis and cardiomyopathy, valvular heart disease, liver disease should also be discussed as a cause. Thank you.